Welcome to today's webinar, The Evolution of Virtual Health Technology for Clinicians and Their Patients. I'm Kim Ellsbury. I'm the Vice President of Digital Health with Cinzy, an AMN healthcare company. I will be your facilitator today. I am joined by home health expert Dan Kevorkian, Vice President, Clinical Innovation and Technology at Accent Care. A few housekeeping items before we get started. Please note that phone lines have been muted for audio quality. Throughout the webinar, you will be able to send any questions using the chat box on the screen. We will try and get to many questions as possible and devote the last 15 minutes of this webinar to questions and answers. The goals for today's session are informational, practical, and with a call to action. We will be covering a brief history of Accent Care's journey into virtual health, including patient and clinician engagement and adoption, what the term hybrid care model means, and how it can impact current and future care delivery. We will discuss thoughts of how to prioritize your digital health investments and scale them to an enterprise model. Finally, we will wind down with a little regulatory talk, including the upcoming public health emergency end on May 11th, and then a special call to action by Dan. Dan, thanks for being here today. Can you tell us a little about yourself, your role in Accent Care?
Absolutely. So I am Dan Kevorkian. I am a physical therapist by trade. I serve as our VP of Clinical Innovation and Technology and have actually been around Accent Care for about 18 years now. Accent Care is one of the largest national home health, hospice, and PCS providers in the country, serving over, I believe, 33 states the last time we looked into that. So I have served a number of roles in my time here, specifically really around building specialty programs, building programs with our JV partnerships, building our BPCI program that we had, other things like hospital at home ED diversion, and telehealth was one of the big ones that I pivoted to during the public health emergency, as it was vital that we had a solution at that time. So that's why I'm here today, and I'm really thankful for you asking me to come, Kim. Thank you.
Great. Thanks for the introduction, Dan. Well, you gave us a little bit of preview of how Accent Care got started with telehealth. Could you talk a little bit more about what it was like in the beginning, and then also what you're doing today and what future problems that you're looking to solve with virtual health?
Yeah, absolutely. So our journey with virtual visits specifically actually started significantly before the pandemic. We started probably about 6 years ago, I believe now, where we knew that we had an issue with treating wounds. And wounds is a very complex care delivery in home health, as we all know. And we knew that we had WOCNs who were available to support our teams, but they weren't able to put eyes on those wounds in real time and really weren't able to communicate. And so we started leveraging actually Cinzy back then to be able to bring our WOCNs into the patient homes with our clinicians, to be able to actually collaborate together, to be able to identify the right care plan, the right supplies, and the most effective treatment plan for those patients. During that, as that kind of progressed, we ended up getting to the pandemic, which everyone is likely familiar with. And it was really forced upon all of healthcare that we needed to come up with some solutions to stay in touch with our patients. We had a very difficult time during that time reaching our patients. Patients weren't allowing us in the home. We all know we've been through it. And so during that time, we decided that we really need to have and beef up our telehealth solution to not only be around wound care, but really to be an adjunct to our care to provide to our patients. And so during that pandemic, we worked with Cinzy to be able to establish virtual care throughout our entire organization, to be able to reach patients that either were not allowing us in the home as much, or to really reach patients when they had urgent needs. And that was something that we really identified as a huge value of virtual care. And we'll talk a little bit more about that. So we really kind of beefed up our telehealth capabilities with training. There were lots of challenges, as everyone can imagine. Technology, we have patients that are good and not good with technology. We have clinicians who are good and not good with technology. And so training continues to evolve, and all of those, and really all of those pieces. In addition to really looking at not only our care, we started looking at how do we actually improve the access to care for patients who are having 30-day waits to go to their doctors at the time that they're discharged in the hospital. Physician wants to see them before they start home health, and they don't have an appointment for another 2 weeks, sometimes a month. That created a huge challenge. And so the other way that we leveraged another one of the Cincy products under AMN was by partnering with sound physicians. And by partnering with sound physicians, we were able to provide a virtual physician during our start of care to that patient to be able to not only assess the patient with the clinician and the sound physician, but to actually be able to build a care plan for the first time ever with a physician, the patient, and the clinician all together, building a comprehensive care plan and addressing immediate needs. It was really powerful to kind of see that in action. We have since admitted over 2,500 patients nationally, leveraging this when we have patients that come to us, which we know happens often without physicians. And so that allows us to get patients started, get the care they need, and really help the health systems that we work with to keep those patients at home. So that's really how the process started, and then it's continuing to evolve every day, I would say.
Thanks for that. Thanks for that, Dan. You started to talk a little bit about it, but there is increasing interest in hybrid care, and you have been a leader. Accent Care has been a leader. Can you talk a little bit more about what hybrid care is in your definition, and then the impact on current care delivery as what you think the future holds?
Yep. So I personally think we've all been providing hybrid care for a very long time. I just think it's starting to be called hybrid care because virtual visits seems like a really new concept. But if you think about home health for the last 20 years, we have been using remote patient monitoring throughout our industry to keep in touch with patients and to have better view into our patients. We have leveraged texting capabilities and messaging capabilities with patients for a long time. And it really is just the video visits that's more new to the home health space. We've been using phone calls as a primary means of communication for a very long time. So what I really see hybrid care meaning is that it is providing the types of care that our patients need at the time that they need it. One of the things and one of the challenges that we all are very familiar with home health because we're here on this webinar, but the industry is not very familiar with home health. And the thing that the industry in general, and I'm talking about the entire healthcare industry, is how difficult it is to reach patients, especially when they need us, right? If a patient's in a hospital or a skilled nursing facility and they have an issue, they can ring a button and someone will be down in their room in a couple of minutes and they can talk to them. What about our patients that might be 50 miles away from an office, right? Those offices that are covering, how do we address those patients' needs at the time when they come up? And that's really where I see hybrid care coming. It's really wrapping our arms around patients that are traditionally disconnected not only from the health system, but even from the home health company, because it is difficult to get in touch with patients, especially in real time. And so what we've really seen is the ability to get closer to our patients, have better communication, and really be able to stay closer to them throughout their entire length of stay, throughout all of our divisions.
That's great. And you touched on it a little bit, but meeting the patient at the time of their needs. When you're thinking about redesigning workflows and incorporating all these things, if I use the phone calls as an example, and now the phone call now gets morphed into other mediums of communication, what are you thinking about and how are you going about designing those workflows?
So I think we're using our historic challenges that we've seen to really try to build better and smarter. I think one of the things that we've really that we all know in our industry, and I know we're sick of hearing it, is that we all have staffing issues. That's going to happen for a very long time. We do all have staffing issues today. We will have them for a very long time. And so what our challenge is figuring out how we provide the same or better level of care even during these staffing these staff challenging times. And so from that standpoint, we really want to think about how do we facilitate the care that we're providing today. And what we found early on is that in these staff shortages, if we try to have clinicians to do both home visits and virtual visits, what we found is that it really does not save time for our clinicians. Because if you imagine a clinician in the home, which I have been, you go to a home, and then if you have to make a virtual visit, you have to go find a Starbucks parking lot, right? Or you got to go find a library parking lot that has Wi-Fi that you can connect to reliably. And so that really does not save time. So what we really also focused on was looking at different models of providing this care, whether it was having a representative at each office that was able to provide virtual nursing or therapy services, or whether that was a regional team that was able to support our offices. We have a number of different models that we use throughout our organization. But in addition to that, what we really found the biggest powerful use of virtual visits was arming our after hours and on-call teams with being able to reach patients after hours. And so that when there was an issue at 2 a.m, that we'd be able to immediately see what that issue is and be able to provide very good advice that's clinically sound with all the information that we can gather at that time. So what we were able to do is really empower our overnight nurses, our weekend nurses, to be able to be at the home with these patients. We actually had a patient, one of the things people always say is, well, not everybody has technology to use. And that's very true. That is a real access to care issue that we have to solve for, especially when it comes to virtual health. Thankfully, that is coming less and less. But sometimes that doesn't even stop our clinicians from getting the job done. We actually had an issue where it was about 1 a.m. where a patient was having an issue with a wound that started draining, and they weren't sure about what they should do. They did not have a smartphone, and so they were just going to go to the emergency room. They actually called our team, and we were able to get them actually to a cousin's house that did have a smartphone. We were actually able to do a virtual visit in the middle of the night, instruct them on how to change that dressing and keep it safe for the morning, and then had our nurse go out there first thing in the morning to verify and make sure everything was okay, saving the family not only the trip to the emergency room, but also the cost and the stress of having to go to the emergency room and wait, especially during the COVID times that was. So, it's really been able to empower our teams to do more with less wait time. The other answer to that was getting a clinician into a car at 1 a.m, who's probably already worked a full day, getting dressed and driving over to that patient's house, which still does have to happen at times. But if we're able to leverage virtual technology to be able to really meet the patients when they need it, that's really where we have huge, powerful abilities to be able to really change the landscape of home health and how we meet our patients' needs.
That's great. That's an awesome ending to that story that you gave for the patient as well as the clinician. So talk to me a little bit about how you've been successful in ensuring adoption and satisfaction for your clinicians. You touched a little bit on training. Can you talk a little bit about some of the successes, some of the challenges, where you are now compared to where you were when you started?
Absolutely. When we started, it was an emergent situation, right? We had to get the ability to meet with our patients virtually if we were not able to get into their homes. And so what we found during that time is that technology can be a bigger barrier than you think. And one of the challenges at the time when we were leveraging our solution was that there had to be an app that was downloaded back in the day when we started with Cinzy. And that caused a lot of problems for a lot of clinicians to not only download that, but then patients. We found that our biggest challenge was our family members not knowing their Apple ID and their password to be able to actually download an app. And so even though it was really seamless and simple from a text message, it caused issues that we learned about, and we quickly worked with Cinzy to update that. Now Cinzy has a direct click to call, click to connect that all happens directly through the web. It doesn't require any kind of connection and downloading of any kind of application. But at the same time, what we learned from the virtual visits that we were doing is it's not just about connecting virtually. It's also about what do you do and what can be done effectively virtually and what cannot really be done effectively. Obviously, you can't do wound care virtually. However, you can watch a family member complete the wound care that they've been taught to do and check off that they are compliant and able to take care of their needs of that patient. What a huge way to start thinking about also discharge planning with a patient, right? Watching them, knowing that they don't have you to rely on right there, but you're able to guide them through exactly what to do and help them. So it really comes down to, how do we train our clinicians who really did not learn a whole lot around virtual care? I know when I went to school, we didn't talk anything about video visits at the time. Now I'm a little bit ancient, but I know it's still not the primary topic of conversations and learning. And so we really, as the companies, need to provide that education to our clinicians on what's appropriate to provide virtually. What are some tips and tricks of how to connect with patients, even though you're not right in front of them? How do you actually connect with your patients virtually and make them feel like they're part of that, and that you're really not cheating them from a visit? Because that's not what we're doing. What we're doing is adjuncting our plans of care to be able to be in the home more often with our patients and having more contacts with them. So it really is about also listening to your clinicians. When we were first rolling this out, became very evident very quickly that we needed to have some specialists that were really trained on this to be able to provide these visits for our patients and be able to support the clinicians so that they would be able to do their home visits that needed to be done for other patients, and that team would be able to support that virtual care. So, it continues to morph. I wouldn't say that we have the one right answer, and I don't know that there is a one right answer, but I think it's a matter of looking at the needs of your population, of your staffing, of your offices and your capabilities, and then determining, what is the best plan of action to be able to meet your patient's needs.
So you touched on the patient perspective. What do you think has been helpful for patients in adopting the technology? Are there a few things that you could just talk to about that?
Yeah, I think one is just that we are getting on in the years. That technology is just part of the normal day-to-day activity for a majority of our patients. Now, that doesn't mean everybody, and I don't have a specific percentage of how many of our population would have smart devices, but we know that grandparents are sharing pictures with of their grandkids. We know that they're using smart devices more often. So as our patients just start adopting technology more often in their regular day-to-day life, it's going to become more consistent that they're using it and more comfortable with it. In addition, as you start seeing more physician offices, now that we've had the omnibus package that was passed and allowed for virtual visits for at least through the end of 2024, and most likely for a long time after that, we have the ability to leverage the fact that physicians are using this more, and it's becoming more part of a routine plan of care throughout the home health industry. I know that there are transitional care navigators using more virtual means, the hospital at home teams using more virtual means. And so I think as it becomes more consistently just used, it's going to become more of a standard of practice. Now, what we do have to consider is that our patients today may need some training on how to use devices, right? And so part of the care plan can absolutely be to train someone to be able to leverage virtual care when it is necessary for their care needs, whether that's to reach out to a physician for urgent care needs or while they're on home health to reach out to our teams. So I think it's really about creating an environment for that patient that they feel comfortable and they feel supported. And at the end, it really comes down to two things: our outcomes and our patient satisfaction. And that's really all that matters in the end. And so how you get there could vary from organization to organization. But in the end, this is a new tool that we have in our toolbox that we should absolutely be able to take out and leverage and start using when we're meeting with our patients.
Great. I'd like to remind the audience that the chat is open. If you have any questions, we'll be entertaining those here in a little while. Dan, you talked about many modalities of virtual health. What do you think have been the game changers as far as patient engagement? If you look at from virtual visits to secure messaging, what are the game changers in your mind?
So from my standpoint and from kind of the home health standpoint, one is allowing for virtual visits from physicians to be considered qualifying for the face-to-face. That was a huge win for the home health industry that has also been extended through this omnibus package through the end of 2024. And so what it's really allowed us to do is go to our partner hospitals and say, I know this patient may not have seen their primary physician for 6 months since they came into this hospital or are being discharged from a skilled nursing facility. Go ahead and send us this referral and we'll talk to the patient about leveraging our virtual partner or our home visiting partner. And so by being able to leverage that, we've been able to reduce our improve our timely initiation of care and reduce our time to start our patients because of being able to leverage that ability. In addition, being able to immediately have access to a physician while you're at a start of care. I know if there are nurses and therapists on the phone doing these visits, I know you can relate to this where you've been to a patient's home and you see a discharge medication list, but you see that they also don't have half of these medications that they're supposed to have and don't have orders for them and have no way to get them. At that point, you're really stuck when you're at the home, right? You've got to try to call the doctor. You've got to try to bring them in and order those medications. Having that access to the physician when they didn't even have a physician allows us to get the needs and the orders that we need right there. We actually had a patient that was referred to us, and when we went out there, found that they had a catheter that was long overdue changing. And so this patient was scheduled with our partners at Sound. And so the virtual physician came in with us and we were actually able to get orders right there to do your urinalysis. We got antibiotics started and we were able to get orders to change that catheter right then and there. Our nurse just happened to have one in her trunk stock and was able to take care of that immediately. So it's really about immediately taking care of patients' needs, which is something that often we don't get to see in home health. There's delays, we need to get out to your home, there's traffic, there's all those things. This really allows us, a portal into their homes, for certainly. Also, what it's allowed us to do and improve care is to really be able to get better at touching our patients more often in the early part of our episodes. When we first started this during the pandemic, we looked at a certain population in Texas. And what we found is that in that population that we did virtual visits with, we actually had a lower hospitalization rate. We did have about 2.5 additional contacts, which were virtual visits during the episode, but there was no difference in the routine care and in-home care that we provided. And what we found is that just by touching our patients, having them have that new mechanism of reaching out, being connected with us, really was able to show a significant improvement in our outcomes. Again, just by being there for our patients. And I think that's really where we're going to continue to see the evolution of just being more real time, being able to more real time address our patient needs.
Great. Well, let's switch gears a little bit and let's talk about investments. How to fund them, how to look at them. We know that there are challenges within all of healthcare, including home health, where there are investments needed. How would you counsel others on the call to prioritize those investments and get to an enterprise-wide strategy to get scale?
Well, we talked about staffing needs, right? That's not going away. And so the more we stress our clinicians with more visits that they have to do, the harder it's going to be to keep our clinicians in home health. But we are able to increase the amount of touches we have with our patients by leveraging virtual visits. And that's really where the investment should look to go. It's really around better outcomes for our patients by being able to connect with them more and not burdening an already overburdened field staff, right? And so we have patients that call in on a Thursday and need a visit on a Friday. why couldn't we do a Friday visit that we plan to do virtually? Or when we're building our plans of care, are you looking at all of the visits and determining, is this really an in-person visit? We know the Medicare regulations say that we cannot replace in-home visits with virtual visits. Nobody's saying that you would, but there's no book either that says how many in-person visits are really needed for a patient. So when you're developing your care plan, you should really be thinking about what are the multiple mechanisms that we can touch our patients and which ones are most appropriate. Is virtual visits appropriate for every patient? Absolutely not. But are there benefits that could be seen by every single patient? Absolutely. And so that's really where you want to focus. And so it really comes down to looking at value-based purchasing, looking at the risks that we have now that specific outcomes are at play, that we are, that our bottom line dollar is going to be impacted depending on how our outcomes are. And so wouldn't that behoove us to be able to get better care and get better at what we do to take care of our patients now?
Great, Dan. Thank you. And I see we've got some questions coming in, so keep them coming in. And Dan, I'll surprise and delight you here in a few minutes with some questions. You talked about, determining success. It's about the outcomes and patient satisfaction. Is there any way that you're leveraging virtual health in order to understand those patient satisfaction and outcomes sooner? And can you talk about that?
Absolutely. So, HCAHPS is kind of a black box for a lot of people, right? We know that most of us leverage a third party that sends out letters, and we maybe get 10% of those back, 15%. If we're great and we have a great month, it's 20%. But who are the ones that are responding to those letters is typically patients that are not necessarily happy with our services or extremely happy. And we don't really get the meat of those patients that we really need to hear their feedback. And so one of the things that we are also doing is leveraging our capabilities with Cindy to be able to message patients on a more real-time basis after visits to really understand, did we meet their needs that day? But more importantly, did they feel like we met their needs, right? We all know that perception is reality. We all have been, the clinicians here have all been out with a patient and done everything we could and thought that we won this patient over. And then we find out that they weren't happy with something that we did. Unfortunately, nowadays, we don't really hear about that all the time until it's too late or until after the patient is discharged and we've sent surveys. But in leveraging real-time messaging, we can get patients to respond back to us. And if there's an issue, we can provide customer service right then and there. And yes, I said customer service in home health. I know they are our patients, but we don't succeed unless we provide great customer service to all of our patients, and frankly, to our clinicians internally as well.
Great. So, during the public health emergency, there was discretion around the use of communication technologies that may not have been fully compliant with the requirements of HIPAA. With the expiration of the public health emergency on May 11th, can you talk about the importance of getting back to HIPAA compliant secure messaging?
Yeah, absolutely. And any kind of virtual connection. Yeah, I think I think it speaks for itself. Right? We were given an allowance to be able to use things in an emergency situation. There was a certain level of risk that people were willing to take to do that. Accent Care actually never did not use any of those non-HIPAA compliant means during the time, just because we wanted to make sure that there wasn't any risk of any kind of interference. But for those that did choose to use non-HIPAA compliant mechanisms, it's really important that you start looking at how you are connecting with your patients today, because the protections will expire after the public health emergency, and you'll need to make sure that whatever you use is HIPAA compliant. And so there are definitely potential penalties for not going that way. So while we know that we did what we had to do at the time, at this point, we need to really revisit how we're connecting with patients, both through messaging, through video communications, and ensuring that it is truly HIPAA compliant during that time, so that we're not putting us or our patients at any kind of risk.
Okay. What about you? You spoke briefly about some of the regulatory changes, the omnibus passing.
Yep.
Any specific items that you'd like to highlight for the audience here?
I think there are a couple things to know. One is a reminder that CMS did include the additional new G codes that are to be used in our care plans. There is the synchronous telemedicine that's video and audio. There's the synchronous that's just audio. So heads up on that. You will have to have those codes for the telephone visits. And then there's also an RPM as well. Currently, they're only collecting those for cost measures right now, but there is a hope that in the future, some of this will be able to be reimbursable under our episodic payment. Now, a couple of things that kind of have gone on in the past couple of months, as well, I guess 4 months now. We're 4 months into 2023. I don't know how we got here, but here we are. But at the end of the year, on December 29th, actually, the president signed into law the omnibus package, which allowed for the majority of the public health emergency expansion for telehealth to remain through the end of 2024. That included the place of service of home to be billable for physicians. And it also included the ability for our face-to-faces to be considered compliant and qualified through virtual if it is both audio and visual. So that was a huge kind of progress forward. We all knew public health emergency was ending, so a lot of people were waiting on bated breath to see what would happen. So at the end of the year, that expanded through the end of 2024. And there are a number of other bills that have been presented around permanently making some of these opportunities and some of these regulations permanent. One is the Telehealth Modernization Act that looked at allowing for the geographic originating site to be at home. So that is one. All of these have been pushed to the Health Committee for review. The next one was the Connect Act that was actually almost a year ago was presented, which again would allow for removal of different restrictions for mental health permanently and all of that. So what I envision, and then there was the Home Health Emergency Access to Telehealth Act that was presented in May of last year. And what that did was, or what it's proposing to do, is to be able to have the virtual visits be counted somewhat towards a billable service. Now, today, virtual visits or telehealth are not considered billable visits under the home health benefit. So they are considered contacts with patients and are not billable towards the PDGM LUPA levels. So if you have a LUPA level that's at 6 and you've only done 4 in-person visits and 2 virtual, you would have a LUPA in that episode. So there is a proposal that has been referred to the Health Committee that would potentially allow for those virtual visits to be considered billable with other regulations. Part of that is that it would be less than half the total number of visits that were done. There's a number of other pieces, but all of those are kind of paused right now as they start really talking. I have this, as we have the omnibus that goes to end of 2024, I have a sneaking suspicion there'll be something big between now and then that really makes a lot of these changes permanent. Because we've seen that it's a benefit. It has not hurt the system in any way. Really, all it's done is helped have access to care for patients that otherwise were not able to get access.
Hey.
Probably a lot more detail than you wanted, but I happen.
No, it's great. I think you need another title behind your name of a regulatory guru.
Please no.
Thank you for all that. Thank you for all that. So just a few more questions, and we'll get into the Q&A. How does the momentum for virtual health keep going based upon the conversation we're having here today? Based upon, I see some of the questions coming in. How do we keep it going?
Yeah, that's a real small question, isn't it? I mean, I think naturally we're seeing technology just be adopted in day-to-day life for our patients. It's no shock that we have an elderly population in home health. And so as we see the patients who had technology when it first started coming out, had the iPhones in the early 2000s, those patients are going to naturally be more inclined to using it. I think we need to continually have options and work with our physicians as well, where patients are at home, to be able to have their physicians talk with their patients during our episodes. It does not necessarily have to be synchronous while we're there, but being able to leverage that ability so that if there are needs, they know they can reach out to their physicians virtually. I also just really think it's going to be just an industry push as our staffing needs continue to be high, that we need to find better and new ways to touch our patients. And I think that we'll continue to see more remote patient monitoring solutions that are hopefully smarter in the future. I think we'll continue to see virtual solutions that patients will just naturally feel more inclined to use. We've been talking about video visits since the Jetsons, right? And it's only just now people are, it's not new anymore, but it still feels new to a lot of people. And so I think a lot of it just comes with us getting more used to technology being part of our everyday lives. And like I said, we're going to have patients that will always push against it, and we have to respect their rights to that as well.
Oh. So Dan, final question, and then we'll get to the Q&A of the audience. Is for the audience, what is one call to action that you challenge everyone with today?
I would challenge you all to look at your plans of care today and look how you are spending your time with your patients, and make sure that when you are in person, that you are getting everything you need out of that patient while you're in person. And look and see if your teams have the ability to have folks not only available on urgent needs, but to have planned calls, to have planned virtual visits for patients that are built into care plans. I really think that is something that's so vitally important in home health. We end up having large times where we don't see our patients. It's not like a hospital where we're checking their blood pressure and vital signs every 4 hours while they're in there, and that we're right down the hallway. It's difficult to get to a patient's home urgently, and so we really need to set up our plans of care so that there's not urgent needs, so that we're able to meet those patient needs, and we're able to solve for those challenges that we know we have in staffing.
Great. All right, you ready to answer some questions, Dan, from the audience?
Let's do
All
it.
right. So the first question really goes to, how do you get the patient comfortable with telehealth, and that it's not a conspiracy, that you're watching every move? This person says that they're have a older generation of patients in a very rural home health agency, and the patients are not tech savvy. Have any thoughts on that?
Yes, I do have thoughts. One is, we're not going to convince someone that there is not a conspiracy if they really believe there's a conspiracy. And so we need to honor their requests and their needs, and not try to push virtual visits. However, there are a number of things that you can do to make people feel more comfortable. If it's a matter of using a device, can you use technology that uses a device they already have, so that they are not thinking that something that you left in their home is going to be tracking them and reporting back to you or a doctor or the government, something like that, right? So it really is important that you kind of understand from your patient, what is the barrier. Also, again, like I said, leverage tools that they have. If they have a smartphone, make sure your solution is able to use their smartphone. And then again, just be there for your patients. Talk with them and understand what their challenges are, and perhaps maybe have an actual demo of a virtual visit while you're in the home. If you have a virtual team, one of the things that you can do is have them virtual into your device to show the patient how it's done, to show how they can hang up, and to show how there's not any connection after that. As far as convincing, I don't think there's going to be any of that, but I think it's just like we do any other intervention with patients. It's really talking through and understanding what are their needs and what are their objections, so that we can meet what they need.
Okay, thank you. And then can you touch a little bit about how Accent Care utilizes telehealth and virtual visits for hospice?
Absolutely. So we're using it in a number of different ways. One is supervisory visits that are required that we will complete at times. We're also obviously for urgent needs. Urgent needs are the one thing that if there is a question and someone needs someone right this second, we're able to visualize that patient right then and there and be able to talk with our with our patient and our caregivers to really help them. I know we also use it during our bereavement process and to be able to connect with our volunteers, with our caregivers at the time to be able to help through the bereavement process. So that's just a few of the ways, but definitely expands our ability to get to patients and face to face with patients and their caregivers in an urgent manner when it's really needed. And we know that those situations arise quite frequently in hospice.
Okay, thank you. There's a lot of buzz lately about machine learning and AI. However, those solutions typically focus on the triage monitoring side of patient care and less on the communication side. How do you envision using Cinzy in conjunction with these technology from a patient engagement communication perspective?
That is a great question. The fact that we're talking about AI and home health is just comforting to my heart. Home health has long been known as kind of the I'm not going to say what we've been known as, but sometimes we're left behind the industry, right? And so this is something that's really, obviously there's a lot of ethical debates that are going on around AI, what's right, what's not right, what is appropriate and not for patients and for machine type learning. But what I really envision is the ability, again, all of these technologies allow us to get closer to our patients. And so the ability to be closer to them allows us to build better relationships and to be there when they need us. And so really where I kind of see things going in the future is through different patient messaging, but being able to have smart messaging, right? Having the algorithms that can ask the questions. Today we work when you call a service or when you try to call a service center, you go through a telehealth algorithm. Basically, it's not health, but you go through a telephone algorithm and they take you down and they can answer questions and then spark things for patient needs. I think we also will get better in providing on-demand education for patients that are needed. I think knowing and tying to our care plan things and tools that patients can have and being able to message those throughout, I think are a real opportunity kind of in the future. So I know that's not a very straightforward answer because I think AI is a very large enigma right now that we don't really know today how it will be used. But I think that's one of the exciting things about the near future is to see how we can get better with care. Again, it all comes down to, does it improve our outcomes and does it improve our patient satisfaction? If the answer is no to either one of those, then it's not something that I would ever want to push forward for our patients.
Got it. For programs like hospital reduction, how are you integrating tools like Cinzy into other technologies to reduce ER utilization? Have you moved from reactive, proactive in reducing these visits? I know you touched a little bit on that, but can you elaborate a little bit?
Yeah, absolutely. And I think it really is around, again, touching our patients more often. I don't know how many patients you have that when you've gone out to them that they went to the hospital and then they came back and you asked them, why didn't you call us before you went to the hospital? And they said, well, I didn't know how to reach you or I didn't call. Meanwhile, they have the folder from your home sitting there with the phone number on it, right? I think part of that is a larger problem, not just that they didn't know to call you, but at the time when someone needs urgent care or has an issue, there's some panic that goes on, right? And so we need to make it so that patients just know how to communicate with us when they need it. So whether that is having a more robust RPM that also includes messaging, or whether you have a team that's able and available to message. I think there's a number of ways to solve for the problem, but I think the issue is really solved by getting early identification of patient changes in condition, which can be done in person or virtually, and then really making sure that your patients know that you are available and this is how you reach when there are those urgent situations. So they don't just go to the emergency room, which we unfortunately in home health see way too often.
As you look to take risk on from managed care, home health patient, as you look to take on risk, Medicare Advantage, home health patients, how important is physician involvement and how do you ensure you have it with fee-for-service PCPs? And then how does the Sound Physician Partnership play into this equation?
Absolutely. That's a great question. So we often don't have buy-in by physicians, right? Especially if you don't have a partnership and you don't have a relationship. So it's really, outside of just even telehealth, the first part is building these relationships with your physicians, especially those that you're sharing MA patients. You both do have an aligned outcome that you're both aligned on, which is improving the outcome and reducing the cost. However, we know how difficult it is to reach physicians when we need them. There was a study that was published that was a retrospective review and a survey review that found, and it was a terrifying stat, that 40% of home health clinicians, now it didn't survey everybody, but it said something like 40% of home health clinicians have never spoken with a doctor. That's terrifying, y'all. We don't have doctors that we can get orders from unless it's from the field. And so it's really important that we continue to build, and we need to find better ways to communicate with our physicians than we do today. We know that we have a lot of paperwork. That's no secret. We know that it's often a burden to these physicians. So, I really see the Sound Physician Partnership playing into some of that, having a physician that's not only available to help us start care, that will also follow this patient for 60 days and will be available during that entire 60 days through this same AMN portal to be able to communicate urgently on demand and be able to bring these physicians in to our home health. I think it makes us smarter, and I think it makes us more connected to the healthcare community. And I think that's really where the key is for that type of partnership, because we know our fee-for-service PCPs, they are, they're seeing 50 patients a day and then are also getting another 100 calls or so. It's very difficult to be a physician today. So I think the easier we can make it for them to communicate, the better solutions we have, and the more support that we can give them through programs like partnerships with Sound Physicians and other transitional groups, I think we'll have more success with getting them on board. But that is a challenge that will remain for a long time to come in home health. Especially where we are reliant on that community physician to provide us orders and be a teammate during that time.
Thanks, Dan. Can you comment on the gap between what we consider best practices and the gap with reimbursement? Talk a little bit about that gap, if you would.
Yeah, unfortunately, we are caught in a time right now where there is a pretty large gap. We are expected that if virtual and telehealth communication is required and remote patient monitoring, that it is part of our plan of care and is not counted towards our qualified visits for LUPAs. So it is. If in its worst, it does sound like we have to provide care that we don't get reimbursed for, right? But the reality is that we are provided an episodic payment, and that episodic payment is to pay for the care that is required for the 60 days, whatever level that patient might need. And so it really also comes down to us needing to be smarter about the way that we look at what is needed for patients. I still see when we talk with others and we talk with some clinicians, we still see those care plans that are 1 week 9, right? We all know that they exist. We all know that they are not best practices. How do we get from that to having a smarter connection with our patients, having a more consistent communication with our patients, and still be able to do it under our episodic payment. I think that's just always going to be our challenge that we need to think through. We are hopeful that, Medicare has done this before, where they start gathering cost analysis of what things are costing before they start reimbursing. And so the major thing is to make sure that you are capturing on your claims all of your synchronous telephone and virtual visits and your remote patient monitoring, so that those can all be taken into account when the costs are associated. And perhaps we can all advocate for better reimbursement for those adjunct and newer technologies.
Great. Well, Dan, thank you very much for your time. Thank the audience for spending an hour with us today. I'm Kim Ellsbury with Dan Kevorkian. Thank you all and good day.
Thanks so much, all.